Hey guys, it's Dr. Dan here. Welcome back to my channel. Today we're going to be doing another reaction video to Grey's Anatomy. It seems like you guys are really enjoying these videos, so I appreciate all the comments and encouragement. And one of my subscribers actually left a comment that recommended this specific episode, and it was a perfect episode. It's one about scoliosis, spinal surgery, and so I'm really looking forward to this one. Let's get started.
Jonah Mays, 18. He was diagnosed with progressive kyphoscoliosis at age 6. He's had multiple posterior spine fusions with instrumentation from T4 to L5 to correct the curvature.
All right, so progressive kyphoscoliosis is what Jonah has here. First of all, I don't recognize anyone in here. I don't recognize this doctor. Is this a new character in Grey's Anatomy? I'm not sure. But so what is kyphoscoliosis? So scoliosis is a deformity of the spine that involves some type of curvature. And typically you see it in the what we call coronal plane, where the curve is from the left to the right. And that's a typical scoliosis that everyone knows about. Now, when he adds this word kypho on top of scoliosis, kyphosis is where the spine is bent forward. So now that we're talking about what we call the sagittal plane, or looking at someone from the side. And when you look at it from the side and they're bent forward, that's a kyphoscoliosis. So he did mention that he had been previously treated with posterior instrumentation and fusion from, I can't remember the level, I think it was T4 to L5. And so this is, we can do a little review of spinal anatomy, right? The spine is broken down into 3 different sections. You have the neck, which is the cervical spine, then you have the mid-back, which is the thoracic spine, and then you have the lumbar spine, which is the low back. And each of those you can classify as C, T, and L. So C stands for cervical, T stands for thoracic, L stands for lumbar. And so now he said T4 to L5. Well, T4 stands for the 4th thoracic vertebra, and the instrumentation was done all the way down to L5. So T4, T5, T6, T7, so on and so forth, all the way down to L5 was instrumented. What does that mean? Instrumentation of the spine usually involves, in these days, some type of screw fixation or pedicle screw fixation, where a screw is placed from the back of the spine and through what we call the channel called the pedicle and into the front of the spine, into the vertebral body. And so instrumentation in scoliosis refers to these screws being placed from the thoracic all the way down to the lumbar spine, and rods that are placed within the screws, and this in turn will help correct any kind of deformity in scoliosis. All right, so let's go on.
Yeah, it's pretty much my entire spinal cord. I've had 15 surgeries in 12 years.
Some due to growth, some due to the condition's progression.
So Jonah here has had 15 surgeries in 12 years, which is an insane number of surgeries for this condition. Is probably not likely. The typical algorithm for scoliosis is usually some type of bracing first to see if you can slow down the curve. Sometimes you just do observation. It really depends on a lot of different factors. But once it gets to a point where the scoliosis is so bad and the patient needs surgery, then you're typically doing one surgery to do the scoliosis deformity correction. So the fact that he had so many surgeries is a little strange. It's not typical for scoliosis, and it can happen if the initial surgery there was some type of complication or some issues. You may need subsequent surgeries down the line, and that might be what is going on here, but it's unclear. All right, let's see what happened in this situation.
Metal rods bust right through his skin. Can we take a look?
You're in good hands, Jonah. I'll leave you to it.
Looks like the degree of angulation has pushed the hardware off the bolts.
He says the degree of angulation has pushed the hardware right off the bolts. So degree of angulation is referring to the deformity, and we measure curves by angles. And so he's saying that the deformity here has gotten so bad that's put so much pressure on whatever hardware is there, and the rod popped right out of the screws and is now coming out through the skin. Now, what's so concerning about that is that now there's an open communication between the outside world and the hardware inside the body, and the main concern here is for infection, is that bacteria from the outside world can travel and seed that hardware, and he can develop a deep wound infection, which is a very serious issue. Anytime hardware fails like this, the only way to treat this is to go back in and to do surgery. And so let's see what happens.
But you can fix that though, right?
Dr. Lincoln and I will remove the rods. We'll insert a nylon tether, which will stabilize your spine. It'll allow room for growth, which means fewer surgeries in the future.
So Amelia here mentioned something called a nylon tether. And so what is this exactly? The exact technique is something called vertebral body tethering, where instead of a rigid rod basically straightening out the spine, you're using a nylon string and connecting it to the screws and basically pulling tension through that string to try to straighten out the curve. Now, the advantage here is that by using nylon, you're not necessarily doing a permanent rigid fixation. The only thing weird about this in this situation is that the patient's 18, so that means he's probably finished growing. At this point, this means that he is skeletally mature and that he's really stopped growing. And because of that, tethering is really only used when someone is still growing around puberty, immediately before or younger, so that as the patient is growing, the tension can be pulled and the curve can be corrected. And she mentions that you can save future surgeries. Well, the whole point of the tether is to try to avoid a fusion operation where you have to put rigid rods, and there's a whole slew of complications and issues that comes with doing something very rigid to the spine, versus a tethering also can be done minimally invasive with very small incisions. So she is right that this is an advanced surgery that can be offered to correct scoliosis. It just wouldn't be offered in an 18-year-old male, in my opinion.
I'm going to give you something to relax you, and Dr. Lincoln is going to mark you for surgery.
Cool.
What are you going to study at Cal?
Environmental science.
So what's going on here is that Amelia is meeting her. So Amelia and what's his name? Oh, so Amelia and Link here are in the Preop Holding area, and they are talking with their patient. And this is actually a time when the patients are pretty nervous. If you watch one of my surgery day in a life of vlogs, I talk about how talking to the patient during this time is a very crucial part of kind of calming their nerves, answering their questions, and that's what's going on here. The only weird thing is she's administering the sedative, and that does happen. We give some medications, Versed, to try to calm people's nerves down because they're very nervous. But usually it's an anesthesiologist who's doing that, not the actual surgeon. So that's the only thing strange here. Link here is marking the patient's back, and this is something that's commonly done. It's part of the surgical safety checklist, and this is done to avoid wrong site surgery. So if you've read in the news some horror stories about someone getting a certain body part removed, and instead of taking the right one out, they took the left one out. Well, this whole marking business is trying to avoid that. And in the spine, really, you're marking the back, and there's no right or left back, but we still do it as part of the checklist, and this is something we actually do in real life surgery.
Signal looks good.
Good. Angle looks good.
All right, so what you see here is a setup for what we call a VATS procedure, or video-assisted thoracoscopic surgery. And this is done using a small incision, and a tube is placed on the side of a patient, and a camera is placed through that tube to basically look around the pleural space, or where the lung is contained, and you can actually access the thoracic spine or your mid-back through this approach. And why do we use camera surgery? Well, using cameras allows us to make smaller incisions. So instead of seeing into the area that we need to see using a big incision, you can make a small incision and use a camera to get to exactly where you want to see. And so this is what you see Amelia doing in this setup. And what Link is doing is he has instrumentation. He has the pedicle screwdriver that he's working, while she is showing him on the monitor with the camera exactly what he's doing, behind the lung. Now, this brings me back very fond memories of medical school. When I was on my general surgery rotation, as a medical student, you were responsible for operating the camera. So I got pretty good at it pretty quickly, and what I realized is using the camera in surgery is actually just like playing video games. And same with arthroscopic surgery, or later in orthopedic surgery residency, you would use a camera to look inside knees and hips and shoulders, and it felt very similar to video games, like first-person shooters. It's kind of interesting. I'm a big fan all the way back from like N64 to Super NES, and I'm a huge fan of video games. I don't have any time to play them now, but I used to play a ton of video games. If you love video games, I want to know about it. Let me know in the comments what video game system is your favorite. I think think there were actually some studies done that showed that surgical residents who were doing some type of camera type of surgery like this, who had played video games, it was actually easier for them and they caught on more quickly. So super interesting.
So, any food allergies? Nancy, you'll want to know.
So if you notice here, what's going on, I mean, they're talking about something, I'm not really sure what, but in terms of the surgery, what's very cool about this scene is that they're actually implementing a technology here that I actually use quite a bit in the operating room, which is CT guided navigation. So you actually saw the line from the screwdriver that showed where Link's screwdriver was in relation to the patient's anatomy. And what you see in this scene here is, if you notice on the screwdriver, there's like a claw-like structure with balls on it. Those are little sensors that actually a camera will pick up in relation to the patient's body, and it acts as a GPS, and it will show you in real time where you are in the patient's anatomy with a certain instrumentation. So theoretically, this should help with increasing safety and being more accurate with placement of instrumentation or pedicle screws, because you can see exactly where you are. So one of the coolest parts about my specialty is that the technology is constantly evolving. So here you see navigation, which is a very cool technology that we use in the OR. There's also robotic spine surgery. There's different types of implants that are being used. So there are always new technologies being invented to try to improve the safety and effectiveness of surgery.
Bending by the minute. He's exaggerating. I'm fine. I'll be okay. Ow!
Jonah, we took a look at your scans and the tether
Please don't
just
say
said
it.
Your lungs are compressed. We're gonna have to replace the rods so you can breathe.
So it looks like, you know, he went through the first surgery okay, but now he's developed a complication. He can't actually breathe well, and he mentioned that the nylon tethers had broken and now the lung is collapsed. So when someone's scoliosis curve is very severe in the thoracic spine, the actual space where the lung is supposed to be can actually be compressed down, and patients could have trouble potentially breathing. So that's what's going on here, and it sounds like a pretty, when anyone can't breathe or is having difficulty breathing, that is a medical and surgical emergency. So it sounds like they're going to be rushing him off to the OR very soon.
Classes here at Community
That's not what I want. Ask me something else.
a vertebral column resection.
What's that?
Dr. Shepard.
We would remove the vertebrae causing the curvature and replace it with a titanium cage that would protect your spinal cord.
It's a very risky, very complex surgery with many potential complications. Could result in paralysis, even death.
Oof. So Amelia here is proposing a VCR, or vertebral column resection. So what is that? So if you think about a kyphotic deformity, we have a spine here, this spine is bent forward, right? So these bones are kind of leaning forward like this. And the VCR is really reserved for only extreme cases of severe deformity, and it is a risky procedure like Link mentioned here. And what ends up happening is you go from the back and you're basically removing this entire vertebral body here. If you take out this bone, then you should be able to correct it and move the spine back into the proper position. Now, what makes this surgery very risky is that you're basically, essentially, by taking out the bone here, the entire vertebral body here is being removed, you're destabilizing the spine. And so the whole point of the spine is to protect the nerves that run down this canal. And especially in the thoracic spine where you have the spinal cord, if you're destabilizing the area that's supposed to protect your spinal cord, you're putting the patient at risk for possible neurologic damage. When you are actually fixing the deformity, there's a pretty high risk for neurologic injury. And so this is why we use things called Neuro Monitoring. I'm going to go into that a little later. Link is right in that this is a pretty risky procedure. Let's see if he goes through with it.
But if it works,
It would permanently correct the deformity.
you can do it now.
I don't recommend.
Yes. It is risky, but if you decide that it's what you want, we could do it.
I want it.
No way.
The patient's brother here has a reaction to a very high risk procedure. And actually, it's interesting. I see this type of reaction happen all the time in my clinic, where I will be explaining a surgery to the patient. The patient's pretty motivated. They've already failed non-operative treatment. They really want to get the surgery to get rid of their pain. And then I start going into the risks of surgery. Well, there's a risk of infection, there's a risk of bleeding, there's a risk of nerve damage. And you can kind of see the patient get a little nervous about that, but it's really usually the family member that gets much more upset about the situation. And so this is a pretty common reaction. So I try to bring everyone in the room into the conversation, make sure that the patient's family also understands the risk, but also we don't want to alarm them. So, I always make sure I let them know how rare the risk is, but it is important for them to get on the same page. And this common reaction that I see from a patient's family is not uncommon. And it makes sense. They're super concerned and worried that their family member is going to be subjected to these risks, and maybe they're not necessarily really understanding how much pain the patient is in. So, it's a interesting balance that you have to keep when you have this conversation and try to address both people in the room.
I could paralyze him. A woman just became quadriplegic on our table.
That was out of our control.
Exactly. There are no guarantees. Our patient has to come first.
I am putting him first. This is what he wants.
This is what you want because you've still got something to prove.
Ooh. Okay, so in this scenario, I can see what Link is doing. He's kind of perseverating about prior complication. Someone became quadriplegic, meaning that their arms and legs stopped working after the surgery, and they were paralyzed essentially from the spine surgery. And so he is still thinking about that, very worried about it. And honestly, lots of surgeons do this. They do think about the worst possible thing that happened to one of their patients in the past, and it kind of could affect your future decision making and the way you carry on your practice. One of the things you can't do as a surgeon is perseverate, but definitely we do think about our worst complications that ever happened, and we try to avoid them, obviously. And so that's what Link is talking about here. All right, so the first thing that you saw Amelia here holding up in the case was a metal rectangular little piece on like a rod, and what she was putting into the patient was the cage, and that's part of the VCR procedure. Remember, we talked about how we're removing an entire vertebral body, and so there's going to be a big space here, and so that cage is usually a titanium implant that we put into that dead space to fill it up, and that's what's happening in this part of the case as part of the VCR. I had to kind of cut the audio out here and just leave music in here because of copyright, YouTube copyright issues. So all we have here is kind of the sound. But just to let you know what happened is that all of a sudden she received an alert on her EMG there, or her Neuro Monitoring system. And so we do use this in spine surgery. This is pretty accurate, especially in a case where the spinal cord is at risk during a VCR. We would be using this system called Neuro Monitoring. So what Neuro Monitoring is, it's basically monitoring of the neural functions through different methods. And typically it happens in my OR is that there's technicians who put needles and electrodes on patients' arms and legs, and those monitor signals that go from the brain through the spinal cord to our extremities. If there's any type of injury in the spinal cord, then you would be able to pick it up in real time, and you can stop what you're doing or check what's going on. And so that's the signal that showed that there was an alert on the Neuro Monitoring, and you saw the look on his face. He was freaking out because he was worried that they had paralyzed the patient. So let's see what happened.
No neurological deficits. How do you feel?
Like I'm going to Cali.
How long should he stay off his feet? A day or two? It's good for him to walk. Ease into it, though.
Your doctors here will oversee your follow-up, but you know how to reach us.
Wait, so that's it?
All right, so no paralysis. He did well after the surgery. This is what we call a post-op check. Amelia's coming by, checking to make sure that he's doing okay. They're talking about instructions after surgery, what to do. She's answering questions, and it seems like he's pretty happy with his results.
Every time you fell down, you got up and came back stronger. But not that you didn't care about falling, but you weren't afraid of it. And that's what makes you.
So this last scene in the episode is a nice little chat between Amelia and her mom, and they are talking about how Amelia has this one quality that we see in all doctors, which is grit. And what is grit? Grit is the ability to withstand hardships and all kinds of crap that gets thrown your way. Regardless of what happens, you are completely dedicated to your goal and to your passion, and you work through those hardships. And I gotta tell you, I know a lot of the subscribers and a lot of you who are watching this video are medical trainees, or maybe in pre-med, or even before that. And the medical journey is a really long one. It is absolutely worth it at the end, but it is a long one, and it requires exactly what Amelia's mom saw in Amelia, which is grit. And it means getting back up when you fail. There's gonna be lots of failures. I can think back to my training days and literally can remember times when people discouraged me. I didn't do so well on an exam. I thought I did something well and the evaluation came back and it wasn't what I thought. And there were some very discouraging moments, but the best way to overcome those issues were really to kind of think forward and think in the future to what I wanted to ultimately do for my patients, which was become a surgeon. So I leave you with this. Grit is not something that just comes overnight. You have to develop on a day-to-day basis. And the best way I found to do this is actually motivating myself through things like watching Grey's Anatomy, which helped me imagine what my life might be like in 10 years. It's not realistic, but I'm just saying that's the things I would do. I would think for the future. You're not going to be doing organic chemistry. You're not going to be doing physics when you're a practicing surgeon. So you have to think about how you're studying right now for your future patients. All right, guys? With that, guys, I hope you guys enjoyed this reaction video. Please leave a comment below on what future show that I should react to. If you enjoyed this video, please hit like, hit subscribe so you don't miss future reaction videos as well. Thanks so much for watching. I'll see you guys on the next one. Hi, Alicia. I'll be right out, okay? Daddy's almost done filming. Hi. Hi, Alicia, what are you looking at? You're like looking at all the microphone and everything, huh? I'll be right out, okay?